Your passcode has been confirmed. If you need technical assistance during your call, press *0.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
I'm sorry, we did not get your name.
After the tone, please state your name, followed by the pound sign.
This conference is in silent mode.
There are 14
Parties in conference, including you.
Webinar series. My name is Shay Pope, and I'm from the Division of Blood Disorders. I'll be serving as today's moderator. As the conference leader, I have muted all the conference lines to eliminate background noise. After the presentation, we will allow questions, and you'll have to press *6 to individually unmute your line at that time. If you have a question, you can electronically raise your hand by accessing the Q&A tab on the menu bar of your webinar screen and click on the hand icon in the upper right corner. This will display your name to the moderator, and I'll call on participants as their names are displayed. You can also raise your hand during this presentation, but we will wait until the end to address those comments. Additionally, this session is being recorded. So today's topic is the road to the evidence-based management of sickle cell disease, expert panel report. Dr. John-Sowah received her BA from the State University of New York at Stony Brook in 1989 and her MD from Cornell University Medical College in 1994. From 94 to 97, Dr. John-Sowah completed a residency in family practice at the University of Maryland, Department of Family Medicine. Her postgraduate training further included a residency in general preventative medicine at the Johns Hopkins University Bloomberg School of Public Health from 2002 to 2004, during which she received her MPH in 2003. Dr. John-Sowah is a medical officer at the National Heart, Lung, and Blood Institute's Division for the Application of Research Discovery. There she serves as the Institute Lead for the Development of Healthy People 2020 and also as the team lead in the development of sickle cell disease guidelines. Dr. John-Sowah has substantial experience in conducting evidence-based reviews as a result of both her current position and her years as a senior scientist in the Medicine and Public Health Unit of the American Medical Association in Chicago. While with the AMA, she directed the development of the expert committee recommendations on the assessment, prevention, and management of child and adolescent overweight and obesity. She also developed the AMA National Advisory Council on Violence and the Abuse Council's continuing medical education program and directed course content as course director for the Linda E. Saltzman Annual Symposium. She authored the Council on Science and Public Health Reports on Emotional and Behavioral Effects of Video Games and Internet Overuse, and the Council on Science and Public Health Report on Obesity as a Disease, which directly impacted AMA policy. Dr. John-Sowah also serves as the AMA representative to the U.S. Preventative Services Task Force. Dr. John-Sowah's clinical experience includes serving for several years as the lead physician in a community-based satellite practice of Memorial Hospital it says in York, I think it's in New York, in York, Pennsylvania, and as a staff physician at the Baltimore Metropolitan Transitional Center, which is a part of the Maryland Corrections System. And now I'd like to turn the webinar over to our presenter, Dr. John-Sowah. If you could please unmute your line by pressing *, and you can begin to address the audience. You might want to try it one more time, Dr. John-Sowah. We still can't hear you. Can you press *6?
Can you hear me?
Yes, we can hear you now.
Thank you. I caught star and I didn't catch the number behind it.
Okay.
Okay, so good afternoon, everyone. I wanted to say thank you to the CDC for inviting me to give this presentation today, and also to thank everyone who's decided to attend this webinar. I was going to start off with a disclaimer, which is probably not the best way to start, but I did want everyone to be aware that I'll be talking today about the process, sort of the road to how we got to the development of the expert panel report, and I won't be discussing the recommendations. The report is not final just yet, and so I can't be able to say, I'm not able to say what the final recommendations will be. Next slide, please. So what I'll do today is take you through some background information that many of you are probably familiar with. Then I'll describe the tasks that we set to the panel, discuss the methods that they used, let you know about what progress has been made so far, and then I wanted to dig a little deeper into the public comment period and what surfaced as a result of those comments, and then we'll discuss a little bit about the next steps. Thank you. So this slide, many of you are already familiar with this. So this is what we are working with. 70 to 100,000 persons in the U.S. are affected with sickle cell disease, and many of those are of African ancestry, although a minority are of Hispanic, Southern European, Middle Eastern, or Asian Indian descent. And currently, the lifespan has increased since 1970. I believe it's doubled. But when compared to the rest of the U.S. population, it's still shortened by 2 to 3 decades. Next slide. This is what the NHLBI knew going into the development of this report. We knew that there's a lack of comprehensive, systematically reviewed evidence-based guidelines in the United States. We also know from other diseases that guideline-based care has been shown to improve outcomes and reduce costs. We knew that there was a need to address this particular healthcare disparity, and if we were able to do so successfully, we could improve the quality of life for the affected patients and their families. And we also know that there was an underutilization of some of the effective therapies that we have out there. In particular, we knew hydroxyurea was being underused. The NHLBI did sponsor the Hydroxyurea Consensus Conference in 2008, which explored some of the reasons for this underutilization. Next slide, please. So these are the things that came out of that particular conference, and I'll just point your attention to a few of them. So on both the provider and patient end, there was a lack of knowledge about hydroxyurea as a therapeutic option. And there was some difficulty in communication between patients and caregivers regarding the use of hydroxyurea. On the patient end, there was a need to frequent monitoring of their response to hydroxyurea, and that also influenced the lack of adherence to the treatment regimen. On the provider end, there were issues of bias and negative attitudes towards patients with sickle cell disease. There was a lack of clarity about hydroxyurea treatment, and in particular to this report, there were a limited number of physicians who have the expertise in the use of hydroxyurea when it comes to the management of sickle cell disease. And so with that knowledge, armed with that knowledge, the NHLBI decided to, next slide please, convene an expert panel to develop a set of clinical practice guidelines. Next slide. So this just lets you know who our panel members are. And I know many of you are familiar with our panel members. I've also included at the very end there our lead methodologist who led a group of independent methodologists in the development of this document. Next slide. Now, our group was, as I said before, small but mighty. We tried to include a broad range of expertise that would be pertinent to the primary care audience, our target audience. So we started with 9 members when we began in 2009, and we are currently up to a 12-member panel. and it includes expertise in family medicine, transfusion medicine, emergency room nursing, obstetrics and gynecology, and then we have our usual suspects, the adult and the pediatric hematologist, and in addition, we do have a psychiatrist on our panel. Next slide. And this is what we charged them to do. This is their task, and that was to develop a comprehensive set of systematically reviewed, evidence-based sickle cell guidelines for both children and adults that target the primary care providers and enhance management of the disease across the lifespan. So even from that, you can start to see how this document has differed from previous documents put out by the NHLBI. You see our target audience is different. We're looking at primary care providers, and our process is different. We're looking at a systematically reviewed document. And NHLBI's goals for clinical practice guidelines development, we're hoping to develop guidelines that are high quality, evidence-based, credible, implementable, able to improve patient outcomes, as well as to identify additional research topics that are needed to inform practice. Next slide, please. So these are some of our key milestones. As many of you are aware, we've been on this road a very long time. Our panel's first meeting was in March of 2009, actually end of February, beginning of March 2009. And during that meeting, they were able to identify the 5 priority topic areas. And that has transformed into the 5 topic areas that you'll see in the final document. Those specifically are health maintenance, managing acute complications, managing chronic complications, hydroxyurea therapy, and transfusion therapy. By May 2010, we'd hit a couple of bumps in the road, but we were well on our way, and we were able to have the second face-to-face meeting. And during that meeting, our panel defined our research questions, refined our search strategies, and these were done with the help of our methodology group. And we also decided that since 2010 was a flagship year, one that marked the 100th anniversary of the publication of the first document on sickle cell disease, and NHLBI was co-sponsoring, along with several of our other sister NIH institutes, the Herrick Symposium. We'd like to have, I guess, the rest of the world look and see a little bit of the work we've done so far, and so we prioritized bringing forth the hydroxyurea chapter. And that was opened for public comment during the Herrick Symposium. Now, there may be some of you on the line who remember or had the opportunity to read that document while it was online. You may recall that it really just dealt with recommendations for the management of adults with hydroxyurea. And since then, the group has worked to expand that, and it now includes the management of children as well as that of adults. Now, our third meeting was in July of 2011. We're up to 12 members by this point, and our evidence reports had been completed, and so the panel was able to start drafting their guideline recommendations and look at possible research gaps. A year later, in July, we were able to start working on getting our outside reviewers, some invited experts, as well as members of our National Blood Disorders program. And we also had our NHLBI Advisory Council members also had the opportunity to review the document at that point and provide feedback. In August of 2012, we opened the public comment period. It was a 3-week comment period that was open to anyone. So at that point in time, essentially, the whole world could have weighed in on our document. And as a result of the public comment period, sometimes it felt as if the whole world did. We received that many comments, and we really appreciated the feedback that we received. New to the NHLBI's process of doing guidelines, as a result of the public comment period, we were approached by 4 of our organizations on the National Blood Disorders program who asked for a second look. And we sought it here at the Institute, and we were able to offer that second look to 3 outside organizations. And We received their feedback and were able to incorporate that into our document, and as of the end of August of this year, we started our clearance process. And what that would mean to all of you is that we're in the last lap of the development of this document. I just have no idea how long that lap is going to be. Next slide, please. So, yes. So what I wanted to also discuss was the method, the process that we used in order to get from no recommendations to recommendations. And any guideline development process, especially one that includes an explicit methodology and an evidence model, is going to follow a series of steps. So for us, the topic area identification, that was basically what we were deciding to charge the panel with. And NHLBI then selected the panel members, and the panel members in turn worked on developing the critical questions that were seen as most relevant. And they were assisted by by the methodologist. The methodology group then conducted the literature search, data abstraction, screening, and quality rating of the studies, grading of the body of evidence, and formulation of evidence tables. And those evidence tables will be available online for folks to be able to take a look and see the studies that were looked at. Now, the evidence tables were then returned back to the panel for their input, but also for the panel to now look at the evidence and decide what recommendations could be made and how those recommendations would be graded. And once that's done, as I've mentioned earlier, there is an external review process, and the document then would get modified as indicated per the comments. And then after that, we would begin the process of dissemination, implementation, and evaluation. Next slide. So our panel used the GRADE system, and GRADE stands for the Grading of Recommendations, Assessment, Development, and Evaluation System. This is a two-armed system that would include the one arm that looks at the quality of the evidence or the body of the evidence, and the other arm that looks at making a recommendation and deciding what the strength of that recommendation would be. In the GRADE system, the quality of evidence arm has four levels: high, moderate, low, or very low to describe the evidence. And in this system, a randomized controlled trial would be considered the highest quality evidence, followed by large observational cohort studies, and down on the lower rungs of the ladder would be considered the smaller observational studies and case series. On the recommendation strength, in the pristine GRADE system, you'd have strong or weak recommendations, but our panel chose to add an additional level, and that level was moderate recommendations. And as many of you are well aware of the state of the science in sickle cell disease, in that it doesn't compare to an area like cardiovascular disease in having as many and as strong studies. This is sort of, I guess the best way to say is that it's where the science meets practice. We added to this consensus statements, and consensus statements took two forms. There were consensus statements that we used other systematic reviews that were done by groups outside of ours, or we used existing clinical practice guidelines. And when we did that, we clearly delineated that those recommendations were adopted from X, Y, or Z group or document. Then there were consensus statements that were made based on the panel's collective expertise when there was no data available. And the reason that this was also added to our methodology was that the panel really wanted to make this document usable in a practical sense, and recognizing that there were areas in which caregivers, health caregivers would have questions and would need guidelines, and there was not science or strong enough science. We were wanting to be able to say something definitive to help just improve the provision of quality care. Yes, so the research parameters that we used, we decided that we would include studies in English beginning from 1970 all the way through July of 2011. Occasionally, and I believe when I say occasionally, that's maybe 2 or 3 exceptions, we ended our review a little bit earlier than July of 2011. But by and large, that's where we ended. And there was only the exception that if there were studies that came out earlier than 1970 that were considered sentinel studies, they could be argued to be included. And we included randomized trials, non-randomized intervention studies, and observational studies in our searches. And when we did include case reports and case studies, they were when outcomes involved harm or where complications were expected to be reported. Next slide. So these are what we're expecting to have available at some point in the process for your consumption, as it were. Full guidelines report, we're hoping that that will be out by fall of this year. An executive summary and evidence table will be available online. Scientific articles and research recommendations, and also, and very importantly, the provider and patient tools and education materials. So this is what we've done so far as our reviews. We've had the NHLBI Advisory Council review. We've had our invited external experts review. The relevant federal agents have been invited to review, and the public comment period has been done. Move forward. The organization's requested review has been completed, and right now we're going through our clearance and approval process. And we anticipate that the release of this document is going to be in fall of 2013, as I just said. And for those of you out there who are thinking, but we're already in fall, the way I see it is fall began last Saturday. So I'm thinking I still have about 85 days in which to get this document done, and I'm working my hardest to get it through. Next slide, please. All right. You can slow that down. I thought that I would dig a little deeper into the public comment and let you be aware of the feedback that we received, because it was really very good feedback for our document. And also, I know people have questioned why has it taken so long, and this is just to give you that insight in what's going on behind the scenes. So last August, when we closed the public comment period, we had received over 1,300 comments. And each comment is looked at by the panel and responded to individually and discussed thoroughly by our panel members. And so some comments would lead to changes in the document, and others simply could not. And the outside organizations, I did want to mention them, that were granted the second look were the American Academy of Pediatrics, the American Society for Hematology, and the American Society for Pediatric Hematology and Oncology. There was a fourth organization that did request that look. Unfortunately, they were unable to complete. Next slide. So here are some of the concerning issues that were raised, and I tried to focus, out of those 1,300 or so comments, I tried to focus on themes or recurring questions as I put together this talk. So on the left, I've identified the issues of concern, and the right just looks at a summary of how the panel responded or tried to resolve the issue. So you asked us, or you told us that the definition of sickle cell disease was inaccurate and didn't include several other genotypic variations. And the panel looked at that and said, yeah, we think that's correct, and so language was revised to incorporate this relevant feedback. You asked us, why was bone marrow transplant not described as a cure? And the panel again went and looked to see what had originally been said about this, and language was changed to reflect that this represents a new hope for a cure. It's still not widely available, and more research would need to be done. You asked again, how was screening defined and used in the document? And there were several questions related to screening. And so we looked at the World Health Organization's guidance for defining what a screening test, and we definitely made a distinction between primary screening, where one would screen before there was evidence of the presence of the disease, and in secondary screening and tertiary screening. You asked, why shouldn't penicillin prophylaxis be continued beyond age 5 years? And again, the panel discussed this extensively, but wasn't able to find evidence that suggested otherwise. Next slide. You asked us, why did the report recommend that pulmonary abnormalities should not be screened for? Well, we went back to the literature. We add more detail to the corresponding section. And so there's no longer a recommendation that you should not screen with pulmonary function tests, but neither is there a recommendation to screen. And this, again, is one of those areas where more science would be needed in order to make stronger statements for the management of patients. So you asked, could the recommendations be more specific about pain management? So, for example, how much, where, when, what type, how often, and what are the alternatives to opiates? And this has been an ongoing panel discussion, but at the end of the day, the scenarios were so wide that the panel wasn't able to dig into all of the possibilities, especially given the science that is there. We were asked, why didn't the report use KDIGO classification for kidney disease? We use the NIDDK classification, and that's found online at this website. Next slide. Hydroxyurea, a big question that we had was, why is there a strong recommendation for the use of hydroxyurea in pediatric patients when it's not supported by the evidence, and hydroxyurea use is currently not approved for FDA in children and infants? Again, the panel went back, looked at our science, looked at the studies, and eventually modified the language somewhat to soften the strength of the recommendation. However, this is something that the panel felt that should be said, and it's been said. Next slide. These are just some more of the miscellaneous issues of concern. So something that came up over and over was the fact that the document didn't address, and I called it the you name it, because it was everything, essentially, that the document didn't address, but our audience felt was important. So that would include everything from neuropsychological testing to what pain meds should be used in the specific settings to nutrition recommendations, and we can keep going. And we recognize that there are lots of areas that we weren't able to address in this document, and unfortunately, we gave a charge to the panel, and the panel had to really hone in on things that could be most relevant to our target audience and what I essentially called the low-hanging fruit. So we weren't able to address everything. The science didn't necessarily support being able to address everything, and we tried to make that additionally clear when we revisited the document after the public comment period. Some of you asked or said that the expert panel should take advantage of this document to re-envision how sickle cell disease is perceived and to promote new terminology. It's an interesting idea, but that wasn't a task that was set forth to the panel, so unfortunately we weren't able to do that. And then another question that was put frequently to us, well, why wasn't more recently available evidence included in the document? So here is the thing when you do the evidence report. As hopefully I outlined in some of the earlier slides, you identify your questions in the front end of the systematic review, and you also identify your time frame in the front end of a systematic review. And so our searches, we'd identify we would end those searches as of July 2011. And so any additional science that comes up, and additional science is always coming up, unfortunately could not be included as part of our original evidence review. However, since it was a real concern, we decided that we would include studies that were published afterwards, but they would have to meet certain criteria, which were multi-center RCTs with over 100 subjects, if the findings would make a significant change to practice and to the recommendations as they currently were. As you can well imagine, there weren't too many studies that did hit that kind of criteria. And for the studies that were important, we could not include them as part of the evidence review process in that formal sense because they were not. However, we are able to include them in the discussion of that particular area, and that's what we aimed to do. Next slide. So you asked, why weren't evidence from other types of studies included? And many people would hand us studies, and we looked at the studies that were suggested from those of you who did submit references with your comments. And we have to say, our inclusion and exclusion criteria were identified at the outset, and therefore, when these studies are also within the grade system considered very low quality studies, and so they would not, their findings could not really be generalized to the population at large necessarily. Then you asked, why isn't the expert panel mentioning patients with sickle beta zero thalassemia? And we tried to be specific in our introduction that for the most part when we use sickle cell anemia, it meant both hemoglobin SS as well as sickle beta zero thalassemia. If we specifically said hemoglobin SS, that would mean that the studies that were found were only in this group of patients and not in the other group, and we tried to be consistent with that across the document. Another great question was, at what age does childhood end and adulthood begin? Because the studies varied, and age designations were inconsistent, we left it up to the clinical judgment of the practitioner and the policies of their respective institutions. There was no way we could make a case for one umbrella statement for age. So now just looking ahead, moving this forward, at NHLB High we had a vision that, or we understand that you can't just develop a report like this, have recommendations, and sort of leave it to the wind to disseminate itself. So we envisioned that in order to get dissemination, effective implementation, and uptake in use, and therefore over the long term improve patient outcomes, we would need to engage a broad base of our stakeholders to help us develop implementation strategies by extracting key messages from the guidelines and working collaboratively in order to mobilize their networks for implementation and finding out what best practice approaches for specific audiences would be, and this would be all part of an ongoing model. Next slide, please. So in June of 2012, we inaugurated the National Blood Disorders Program here at NHLBI, and it's an organization of organizations. Currently, there are about 20 or so members, And their purpose was to have a collaborative national effort to improve the care of persons with blood disorders by implementation of evidence-based guidelines to prevent, detect, and treat complications. And I did say blood disorders, not specifically sickle cell disease. Our original vision was that it would go broader, but we would start with what we had, which is this expert panel report that does focus on sickle cell disease. And our key strategies would be to create this collaborative effort among the stakeholders to leverage their unique partner resources and assets. We would improve the translation of cutting-edge research by putting into practice recommendations from documents like the expert panel report, and that we would develop and disseminate tools designed to provide the blood disorders community current, culturally sensitive, and easily accessible information, and we would be partnering with our stakeholder organizations to do this. So when last we got our group together, we were working on just finalizing an overall strategy to disseminate this report and implement the recommendations. And we were looking ahead at how we can work on the creation of the key messages, identifying and creating those key messages, materials, and tools to increase the use of the best practice. So here's where my discussion ends today. And I just wanted, again, to thank you for allowing me to be able to speak on behalf of our expert panel today, and thank our panel for the work that they've put into this endeavor so far.
Thank you so much, Dr. John-Sowah. That was a great presentation. Right now, we're going to go ahead and open the lines for questions. For the audience, please remember to unmute your phone individually by pressing *6. If you have a question, it'd be great if you can raise your hand electronically, and of course I'll call on your name as they're received on my screen. However, in light of the Sickle Cell Disease Association of America conference that is going on right now, we're only going to be taking questions for the next 10 minutes or so. Then I'll have a couple of announcements, and we'll go ahead and conclude this webinar. So I'll go ahead and open the lines for questions. If you have them over the phone, you can just unmute your line and pose your question to Dr. John-Sowah. Any questions? Okay, I don't have any questions coming through on my screen. I'll give you a few more seconds to either post a question from the toolbar or to unmute your phone by pressing *6. Okay. Well, I will go on to my announcements. If you do have a question during the announcements, please feel free to chime in. Our next webinar will take place on Thursday, October 24th, titled Current Data on Efficacy and Effectiveness of Hydroxyurea in Children with Sickle Cell Disease by Dr. Winfred Wang. And then for November, even though we typically do not host webinars in November and December, this year we've invited Dr. Charles Quinn to present his talk on improved survival of children and adolescents with sickle cell disease. Dr. Quinn's webinar will take place on the first Thursday in November. That's November 7th, and it'll be at the same time from 2 o'clock p.m. to 3 o'clock p.m. Eastern Time. If you have any questions about the webinar series, you can contact me, Shay Pope, at spope@cdc.gov. Additionally, if you don't currently get the email blast with the webinar information, you're welcome to contact me, and I can add you to that list. So before I disconnect, I just want to make sure there weren't any questions for Dr. John-Sowah about her presentation. All right, great. Again, I'd like to thank Dr. John-Sowah for putting together such a thorough presentation. I definitely think this information will enlighten a lot of us. When the guidelines do come out, we'll have a really good understanding as to how they were produced, and I think people will have a greater appreciation for them. So thank you all so very much. Have a pleasant day.
Thank you.
Bye-bye.